I now would like to introduce our next presenter. Our next presenter is Erin Harlow-Parker. She has worked in the field of child and adolescent psychiatry for 35 years. She received her BSN from Rhode Island College and her MSN from Northeastern University in Boston, Massachusetts. Her practice areas have included inpatient, outpatient, consult psychiatry, and behavioral and mental health illness prevention work. Erin is currently a manager of child advocacy programs, behavioral and mental health at Children's Healthcare of Atlanta. Her passions include suicide prevention, treating patients with eating disorders, and reducing mental health stigma. She is actively involved in state behavioral health initiatives to improve the behavioral health needs of children across Georgia. In 2018, she was awarded the Institute for Healthcare Improvement and National Patient Safety DAISY Award for Extraordinary Nurses. Ladies and gentlemen, Ms. Erin Harlow-Parker.
Thank you, Kedrick, for that kind introduction. And it is truly an honor for me to come and talk to you all about something that is very near and dear to my heart, both professionally and personally. Before we get started, I'm really curious a little bit about who's in the audience. So I can guess some of it because I've heard you say what you are, but how many are pediatricians or family practice docs? Who raise your hands? Okay. And how many are nurse practitioners or PAs? And how many students are in the room? 2. Okay, great. It's really helpful for me to have a good understanding of the audience I'm speaking to. So today we're going to talk about addressing suicide in the primary care setting, and really how we talk about it is going to be the biggest focus of that. I have nothing to disclose. And today, from an objective perspective, we're going to spend some time talking about the role that stigma plays in talking about suicide and how that gets in the way of that. Understanding things like risk factors, warning signs, and protective factors related to suicide. We'll talk about some evidence-based screening tools that are available to you and how to use some of them. And then really spend some time about how do we have these difficult conversations with kids and caregivers when a child screens positive for suicide or is talking about suicide, and understanding the role of safety planning and lethal means counseling. So let's start from a place of why are we even talking about suicide? Lay some foundations. So what we know is that 1 in 6 youth in the United States, ages 6 to 17, have some mental or behavioral health diagnosis, and this comes from the National Alliance of Mental Illness. And then more specifically from the CDC leading causes of death in 2021, we know that suicide is the second leading cause of death in children ages 10 to 14, and the third leading cause of death in children ages 15 to 19. So at the end of the day, this is something that we have to talk about. As uncomfortable as it might be, we can't ignore it. So why can it be so challenging to talk about suicide? I'm going to start by sharing a video that is incredibly personal to me. It is a video that myself and my daughters filmed this spring as part of my team's work on raising resilience. We faced a family tragedy in 2022 related to suicide. And as an expert in this space, I knew it was an opportunity that I could share my story from a lived perspective to further educate and decrease stigma. So please join me in watching this story, and we're going to talk a little bit more about stigma and things that get in the way. Jeff was a goofball, loved sports, loved music, loved his kids, was the life of a party all the time. We met when we were 19 years old. And we grew a relationship for 36 years. And he died by suicide on January 14th, 2022.
I think my dad was a really cool person. He was really funny. Yeah, he was hilarious, and I think sometimes it would annoy us, but I would do anything to hear Yeah. Jokes again from him.
Transit was incredibly important to him, people having access to their lives, and really dreamed someday of running a transit authority, and that dream came true when he became the CEO of MARTA.
He was very personable, and if
Yeah.
you ever took the train with him, like, knew the operator's name, always said hi to the person cleaning the station or the person attending the fares.
So when we first learned that Jeff had died, I wanted the right story to be told. By calling it what it is from the get-go, saying suicide, removing that shame that often is associated with that, was an opportunity to educate and to decrease stigma. I am an advanced practice pediatric psychiatric nurse at Children's Healthcare of Atlanta, and suicide prevention has been an area of expertise of mine for more than a decade, which made it even more important and also really hard to talk about. I often get asked, did you know, was there any signs? For Jeff, for sure, there were no signs. This was a complete and utter shock and surprise to our family. He did not struggle with any mental illness. It's an assumption that someone who dies by suicide must have a diagnosable mental illness. And the other thing that I heard a lot was everything seemed perfect. You didn't seem like the kind of family that this would happen to. And I think that really speaks to misconceptions and myths related to suicide. It's a certain kind of person, a certain kind of family that this happens to. And at the end of the day, what we know is that suicide doesn't discriminate. This can happen to anyone. We live in a society where expressing your feelings, specifically of men, is still not accepted and seen as a weakness. My guess is that's something that Jeff was struggling with, and that many people struggle with, not being able to express themselves. If we don't change the narrative, we're going to continue to have people who won't seek out help. The way we're going to get at stigma is begin from birth to normalize those conversations around feelings and emotions, which we know build and foster resiliency.
I think we've both shown resilience. Life is hard and complicated and messy, and
Not everything is gonna happen the way you think it is.
it's important to learn that at a young age. I think it maybe will allow you to not stuff things in as much.
Part of being resilient is understanding your feelings and emotions, being able to express them, being able to know what they are, to identify them. I was not able to save Jeff's life. But what I can do is use my voice in the hopes that we can save other people's lives. Suicide can be prevented, and it can be prevented by connection, by talking about it, and most importantly, letting that person know that you're there for them. Hey, I'm worried about you. Something seems not right. I'm here for you. If someone is talking about suicide, no matter what their age is, take it seriously. It is not typical for any person, regardless of their age, to talk about suicide. Get them help. Nationally, we have the suicide hotline number at 988. And it's staffed by licensed clinicians 24/7. There is help, and you can help save a life. So thank you for allowing me this opportunity to share that video. When we created it, I didn't intend to use it as a teaching tool. I was asked to do it in a community event, and for the first time, despite many times of teaching, I saw an audience shift and pay attention in a way I had never seen before. And I knew that it was an opportunity to use this video as a teaching opportunity. And we're going to talk a lot about some of the things that I mentioned in there a few slides down about the importance of starting early in these conversations and normalizing conversations around feelings. But first, I want to touch on some concepts of what gets in the way of us talking about suicide. Things like negative perceptions related to suicide, that people who are thinking about suicide, people who die by suicide, are selfish or weak. When we portray these these kinds of concepts, it prevents people from accessing help and talking out loud about what they might be struggling with. Things like fear. I don't know what to do next if I'm presented with someone with suicide, or I don't know what to say next. I might be embarrassed if I'm struggling with thoughts of suicide, or if I'm a family member who's left behind after suicide. What if I say something that makes it worse? That shame is really a powerful feeling that people struggle with. That shame is what gets in the way of people seeking help. But it also gets in the way of the families who are left behind in receiving help and feeling okay to talk about it. Yeah, this is where I always struggle on this dang thing when there's not a clicker. There are also a lot of common misconceptions out there, and you heard me address some of those in our video, that anyone who tries to kill themselves must be crazy. And what we know is that not everyone who dies by suicide or even have thoughts of suicide has a diagnosable mental illness. We do know that people who have diagnoses such as anxiety or depression are at much higher risk than the general population, but not everyone has a diagnosis. That if they're talking about it, they won't actually do it. So we don't need to take it seriously. We know that we need to take it seriously 100% of the time. If a person is determined to kill themselves, there's nothing that I'm going to be able to do to stop that from happening. And we know that there are lots of things that we can do from a prevention perspective. And people who die by suicide are unwilling to seek help. When in fact, what we know is they don't know how to access the help. They don't know what to do because of all those things I mentioned in the previous slide. And this last concept is something that I've heard many times in pediatrics, specifically when I worked on the psychiatry consult team, and my job was to assess for suicide. And I'd have families say to me, I don't want you asking my kids that because I don't want you to put that thought in their mind. And what we know is no research to support that to be true. Talking about suicide will not cause someone to be suicidal. So how do we talk about suicide? We really need to move to a place where we start moving away from language that is stigmatizing. And that includes saying things like committed suicide, killed themselves, successful suicide, completed suicide, failed attempt, or unsuccessful suicide. Specifically, the word committed, which you often hear, although far less than before, is often associated with crime. So you can see why it's a language that we want to move away from. Instead, we say died by suicide, suicided, ended their life, took their life, or attempted to end their life. I have no problem correcting someone, and I've never had anyone be offended when I've corrected them, especially if I've done it with kindness and compassion. It's really important for us as healthcare providers to understand what are the risk factors that exist with regards to suicide. The number one risk factor is having a previous suicide attempt. So if you're taking care of a patient and you know that is in their health history, that is a patient you want to pay extra care for with regards to assessing for future risk. When someone has a close family member or friend who has died by suicide, in my world we call that the ripple effect. So those that are immediately around that person. When my husband died by suicide, because I am a helper person and I felt completely out of control, in addition to making sure that the press release called it suicide, I wanted to make sure that the executives at MARTA had the support that they needed. I knew that I could get that for myself and my daughters and my immediate family, but I wasn't so sure that an organization that this wasn't their specialty would have that in place, and they were at high risk. Experiencing abuse, neglect, or bullying, social isolation, lack of support, impulsivity or aggression, easy access to firearms and medications. We're going to spend a lot of time talking about lethal means counseling. But people who are at high risk for suicide, the recommendation is, in fact, firearms to be removed from the home, ideally. And if that can't happen, then they're safely secured. Alcohol or substance use disorders put someone at higher risk. Diagnoses such as depression, anxiety, bipolar disorder put people at higher risk. Within the pediatric population, those same risk factors exist. Sometimes the nuances look slightly different in kids. So we want to pay attention to significant changes in their eating or sleeping habits. When they're becoming withdrawn from their friends and their family and their regular activities, the things that they once really enjoyed, they no longer find joy in. And that doesn't mean the child who's sort of trying to find out where they fit in and they're trying this sport or that sport. They've been passionate about lacrosse their whole life, and all of a sudden they don't want to do it anymore. Those are the kinds of things that you need to be paying attention to. They have a lot of physical complaints, so those somatic complaints that they'll often arrive in your office. We know that research tells us that those who die by suicide, a very large percent of them had seen a medical provider in the year prior to their death. But likely we had not asked the questions about suicide because it isn't something that we feel very comfortable universally screening for. And being aware of those warning signs. And the warning signs aren't necessarily warning signs that you have to hospitalize someone over, but that you need to put a safety plan and an approach in place. So anytime someone is talking about suicide or wanting to die, we're going to take it seriously. You heard me say that in the video. I can't say it enough times. It does not matter what age the child is. It is not typical for a child to talk about suicide. We have had children in our state of Georgia as young as 7 die by suicide. A very small number still happens, and we want to take it seriously. Anytime they're talking about death, mood changes that are significant and major, excessive engaging in reckless behavior, and we're not talking about typical teenage reckless behavior, excessive reckless behavior. Giving away things, saying goodbye, those are times in which we really need to be paying attention. But it's also really important to understand what are the protective factors. What are things that we as healthcare providers can do for our patients and encourage those families to do for their children, that wrap them around and help support them. This afternoon, my colleague is going to talk a lot about how do we build resiliency in kids. That's a huge protective factor. So coping and problem-solving skills, which lead to resiliency, are things that we can do proactively that can protect against something like suicide. Cultural and religious beliefs that discourage suicide can actually be a protective factor. You heard me talk about connection. It's very powerful. And when I think of your role as community healthcare providers in small communities, which likely you know everyone in the family and you know lots of people in the community, especially if you work and live in the community, you provide that opportunity for connection. But that could also be their friends, their coach, their religious leaders, their family. Supportive relations, again, with that care provider. I entered every clinical interaction with a child and family, even if I was only going to see them once in the emergency room, with this motto at Children's is today will make a difference in the life of a child. And that I took seriously every single time that I knew I had an opportunity to be a connection to a child in crisis. The availability of physical and mental health care. And we know in rural communities that the mental health care is not always available. And so sometimes you have to be both. And then again, another protective factor is that limited access to lethal means among people at risk. And that includes firearms, suffocation devices, and medications. So I think that it's really important that we as healthcare providers understand that suicide prevention really can start from a primary prevention perspective. And we're going to spend some time talking about that. How do we set the stage that allows for opportunities for kids and caregivers to talk to us about suicide? So let's talk about Mr. Rogers, and I love this quote. People have said, "Don't cry," to other people for years and years, and all that it has ever meant is that I'm too uncomfortable when you show feelings. I'm really curious, and you can call it out, to think about your childhood and your upbringing. What kind of messages were you given growing up about feelings and emotions? This is my third talk of the week, not on suicide, but around feelings and emotions. People always hesitate to say what their feelings and brave, so I usually out myself. So I cried very easily growing up, and I still do, not as much as I did prior to having children, for somehow it changed in childbirth. The ability to cry didn't happen quite as much. But my mother used to call me, "Stop crying, stop being a Sarah Bernhardt," which was an old school actress, even before my time, who could cry on a dime. Now, my mom just didn't feel great and comfortable with my tears and my crying, and probably thought I was being a bit dramatic. Was she a bad mom? No, not at all. She just didn't like it, didn't feel comfortable for her, and that's how she was raised growing up. I'm curious if any of you all were told other kinds of things, to not cry or not to be mad, or boys don't cry. I see some nodding. Yeah. You're not hurt, so don't cry. So crying is only associated with something physical, right? Don't be so sensitive.
I'll give you something to cry about.
Oh, I definitely heard that too. I'll give you something to cry about. I 100% heard that from my mother. Yeah. Yeah, so we are told these kinds of things very often as we're growing up. And likely some of us have shared some of these things, maybe not to the degree that our parents did to us, but likely we've shared those to our children because we don't feel good about those feelings. I love to share the story of 2 years ago, I had to move my dad into assisted living. And when we were finally leaving, my sister and I, and he was in a dining hall that looked very similar to this. And he began to cry because he knew we were leaving. And my sister started to cry, and I could feel that I was going to lose it as well. And a person came over that worked in the assisted living and ran over to my dad, and a sweet woman, and said, "Oh, please don't cry. You're breaking my heart." And in that moment, I said, "Dad, it's okay to cry. This is scary and overwhelming. And guess what? I'm going to be back tomorrow, and I'm going to see you tomorrow." And then an elderly gentleman sitting at the table spoke up and said, 3 weeks ago, when I moved in here, I cried at the same table, and it's okay. And I'm here for you, and I'm going to support you. And this man was like 84 years old. And it just warmed my heart that he felt safe enough to be able to share his feelings in that moment. And I think that that's something that we really need to get better at and being paid more attention to, the messages we're sending children about feelings. Instead of saying that feelings are good or bad, positive or negative, that we move to a place where we say that all feelings are okay and normal. And we're creating spaces as healthcare providers that says that our kids can talk to us about anything. So the American Academy of Pediatrics and the American Foundation of Suicide Prevention collaborated with experts from the NIMH to create this blueprint for youth suicide prevention educational resource for pediatric health clinicians. So when I was preparing for this initial lecture that I did for the Department of Behavioral Health and Developmental Disabilities this summer, I came across this blueprint. And I actually think that they did a really great job creating some guidelines for pediatricians to sort of think about how do you create this welcoming environment that allows for opportunities for patients to feel safe about talking about anything. And that starts with talking to your clinicians and your staff and yourself and reflecting on what your biases are in general, but specifically around mental health diagnoses and disorders. Using inclusive and reflective language and imagery. Think about your practices. Are they reflective of the community you're serving? Does it feel welcoming to them? Being specific about asking your patients their names and their pronouns and then using those consistently. And utilizing what we call those trauma-informed approaches and principles that support and promote relational health. I couldn't say more about the importance of relational health, which really speaks to that idea of connection. And I'm going to make an assumption here, but I think I'm probably on target, that you all in small communities got this going well. I'll bet you all do this super well, and that those of us in the urban space could probably take note and model more of what you all do with regard to relational health, because you're often it for them. We also have opportunities to support emotional expression. Rachel's going to talk about this more in the afternoon, but I'm going to touch on it. And that really starting as early as the time the child becomes verbal, or modeling what that looks like for the pre-verbal children, about how to identify and label our feelings. These aren't things we aren't born knowing how to do. We have to be taught. We're pretty good at helping babies figure that out because they don't have verbal skills, and we talk for them and we say, "I wonder if you're sad, I wonder if you're hungry." But as kids grow and develop and get verbal skills, we don't do that as well. So they don't learn the layers of feelings. And so we want to encourage families to look for opportunities to routinely and openly talk about feelings. And that might look like at the family mealtime or on the way to and from school. How was your day? What was the best part of your day? What was the hardest part of your day? Simple things like that help open up doors to allow communication to occur. I wonder statements, I talked about it using with babies, but we can use them with older kids as well. I'm wondering if you're feeling frustrated. Is that right? It's not me telling the child how they feel. It's me getting curious and asking for clarity. We can also promote emotional expression through these communication strategies that we all learned at some point in our careers, probably. Open-ended questions, active listening, reflective listening. When I was on the psychiatry team and I would come out after I'd done an assessment, I'd gather all the information and the attending or the nurse would ask me, what did I learn? And I would share what I learned and they were like, how did you get all that? This is how I got all that. These are the strategies that I used. I sat down, I leaned in, I nodded along. I exuded a sense of presence for them. I said, what was the hardest part of your day? Child responded, I didn't have anyone to sit with at lunch and it was so embarrassing. I reflected back. It sounds like lunchtime didn't go as well as you hoped. Is that right? We also can promote emotional expression by normalizing, validating, and allowing all feelings. I can understand you might feel that way. I've had that happen to me before too. It's normal to feel embarrassed. I couldn't tell you how many times when I've said that I had a similar experience to a child and they think, really, you did? Because they can't imagine anyone else ever experiencing what they're experiencing. And it is so rewarding and helps with that connection. So as we wrap up thinking of this prevention approach, we can encourage emotional expression. We can proactively teach coping skills. I really truly encourage all of you, if this isn't a part of your clinical practice already, to think about where in your visits, whether that be a well child visit or a follow-up visit, can you reinforce the proactive practice of coping skills? Meaning you're encouraging kids and caregivers to look for opportunities to weave coping skills of any kind. And that might be listening to music, going for a walk, writing in a journal, to more structured ones like deep breathing or guided imagery on a daily practice. And the way we set it up is this is how we manage what life throws at us, whatever that might be. We're going to educate on mental health. I've heard the word mental health talked about a lot. And interestingly, I think even in healthcare, when we talk about mental health, we talk about it as if we're talking about mental illness. Mental health is like physical health. Mental illness is a part of that. Mental health is what we do to stay healthy from a mental perspective. So helping families understand that, but then specifically educating on the connection between our physical health and our mental health. And an amazing way we can do that is through our healthy habits. Strong for Life, that's what we're all about, our healthy habits. So when we're educating our families on the importance of nutrition, we make that direct connection of how it helps us be physically strong and mentally strong. And being very intentional in that. And as healthcare providers, we have a great opportunity to do that. We also can educate kids and caregivers about suicide. And what's really important is that we avoid language that creates this sense of crisis with regards to suicide. And while we definitely know that suicide rates have been rising, when we use the word crisis, it often puts so much fear in someone that they don't hear the rest of the things. But instead, we offer hopeful messages, that they're not alone and that help is available. If we're going to be screening in our practices for suicide, that we explain why we're doing this. And I have some examples of some scripting that you all could use in your practice if you choose to screen for suicide. And then we make it clear that we take it seriously, and this is important to us, and we use compassionate language. It's really important that we educate both kids, specifically older kids, and caregivers on the risk factors, the warning signs, and the protective factors of suicide. And of course, in pediatrics, we know this, that we always want to use age and developmentally appropriate language. This next one's kind of tricky because it's a little scary to talk about something. And you heard Dr. Mann mention this isn't something you all are trained in medical school, really understanding and knowing about mental health. As an undergrad nurse, I wasn't either at all. I had one 6-week session of behavioral mental health, and that is it. So it isn't something we know a lot about. And when we don't know stuff, we end up sometimes inserting our own fear or judgments when we talk about suicide. And it typically comes from a place of we don't feel comfortable, we don't have all the answers. It's really important that we address confidentiality. So the way I always address that is what you say to me is so important, and I can keep it confidential with the exception of things to do with your safety or the safety of someone else's. And I start that out anytime I interact with a child, regardless of what the assessment context is. We're going to start early, we're going to ask often, and we're going to be direct. So I'm going to spend this next bit of time talking about some of the evidence-based screening tools that exist for pediatrics. And I'm going to apologize in advance because I cannot stand busy slides, and these next few slides are quite busy. But they're busy, purposeful, not for us to read them all, but just to let you know that this exists for you to look at. So the NIMH has on their website a care pathway. And if you're someone that really sort of likes some structure to that, I wanted to at least visibly show it up there for you. And I think that it's particularly helpful for people when they're starting from a place of unknown and they really need to know, it's like, okay, this is what I do here. If it's positive, this is where I go next. If it's negative, this is where I go next. And this does a beautiful job outlining that. So basically the child comes in, you're using your screening tool, the child screens positive, then you sort of move to the risk assessment of what level of risk, and we're going to talk some more about that, and then it moves through the flow chart. So the American Academy of Pediatric recommends suicide screenings in the following ways. I'm going to put a caveat to this. I appreciate that this is the recommendation from American Academy of Pediatrics. But those of you specifically in rural areas may not have access to a lot of behavioral mental health services to support a positive screen. So you may not choose to screen universally. But I do highly encourage you to at least screen kids that are in the high-risk populations. Because I can tell you right now, they're likely having thoughts of suicide. And it is much better that you know that because you have an opportunity to intervene sooner. So I'm just going to say what the recommendations are, but I also appreciate that you may have limitations. So the recommendations is that we universally screen all children 12 and older. And when we think about universal screen, the plug I want to give is when we do universally screen, we're creating a sense of that this is just something normally we do in our practice. This isn't something that we're just sort of hiding behind and we're whispering about, right? And that with kids from ages 8 to 11, that we're going to screen only when it's clinically indicated. And then kids under the age of 8, we're not going to screen because the tools are not evidence-based for this age category. But of course, we're going to evaluate and assess, likely with a mental health professional, if children are expressing thoughts of suicide or are having warning signs that are of concern. So the ASQ is one example of an evidence-based screening tool that I'm going to talk about in a few slides. But as part of, on the NIMH, where we have that care pathway, there's also a toolkit that includes the screening tool, but a lot of scripting on how you can talk about the screening tool in your pediatric primary care setting. They also have one for the emergency room scripting. They have one for the hospital setting. They've done a really great job sort of working that through. Dr. Lisa Horowitz is the primary researcher behind this tool, and I have had direct conversations with her for years because this screening tool we use at Children's, and before we brought it to Children's, she was very readily available. So I do say that if you go on this website, you'll see her contact information. If you email her, she actually gets people, she emails you back. That's how passionate she is about this. So this screening starts from a place of what do you say to the parent and guardian about why you're screening? Once the parent steps out, what you say to the patient. If the child screens positive, then what do you say? And it really gives you language. And you literally could read from it until it becomes your own if that's what you feel comfortable doing. The next is the actual ASQ screening tool. And I think that what is important to know about the screening tool is that it is a 5-question screening tool that helps you distinguish whether it's an acute risk or a non-acute risk. So the first 4 questions, if they are negative, you don't go any further, meaning the child says no. If they say yes to any of them, you ask the 5th question, which assesses the acuity level, right? So if the 5th question is, are you having thoughts of killing yourself right now? If the answer is no, then it's a non-acute risk, meaning you likely have to put together a safety plan and things like that. If the answer is yes, it's an acute risk. And that's where you will escalate it up and refer out likely in your clinical practice. Or at least if you are lucky enough to work with a co-located mental health professional, you can have that person do a further assessment. The next evidence-based screening tool, it's the ASQ, but some of you may be using the PHQ-9A, which is for adolescents, the depression screen in your practice, and that's just your standard practice. And you don't want to universally screen, but the question 9 is a specific question related to suicide. And if the child screens positive, they have combined these tools together so you can go right into assessing using the ASQ. I do want to say that it's really important to understand that the PHQ-9 is a depression screening. It is not a suicide screen. And that is really important to know. So if you thought that you were using this tool to screen for both depression and suicide risk, there isn't evidence to support. There's lots of evidence to support that actually we've missed a lot of children who are actually having thoughts of suicide that don't screen positive on this tool. So I do encourage you that if you're going to use the PHQ-9 and not screen universally for suicide, that you join this with the ASQ or this next tool that I'm going to talk about if the child screens positive on question 9. And the last tool that I'm going to talk just really to show you is the Columbia Suicide Severity Rating Scale. And like the ASQ, it helps you determine acuity, whether it's an acute risk or a non-acute risk. And then you're able to determine next steps based on that. So the next we're going to talk about this idea of a brief suicide safety assessment, or a BSSA. And this is, again, I appreciate you all may not be very comfortable with the idea of even going down a path beyond a positive screen and then sending the child to a mental health professional or an emergency room for a further evaluation. If that is what you choose to do, then that is what you choose to do. But what we do know is that when we send a child to the emergency room every time they have a positive screen, it can result in the kids not being truthful on a screening the next time. So that is really important, because not every child that screens positive needs to be hospitalized. And so becoming more familiarized with this BSSA, I highly encourage you to do. Read it. That toolkit that I mentioned on NIMH walks through with scripting on how to utilize the BSSA. So what the BSSA is, it's not a screening tool. It just helps you identify risk to be able to understand what are the next steps that I have to do. This is a super busy set of slides, but I really wanted to visually show you what a BSSA looks like. And basically what it does is it's a tool that walks you step by step, written out, you can read it, to help you understand risk. The first is around suicidal thoughts. And so it asks about, in the past week, have you had thoughts of suicide, and how often? And are you having the thoughts now? If the child is having thoughts now, and the answer is yes, you don't go any further on the BSSA. That is an urgent risk. That child needs further assessment at a mental health facility, at a receiving hospital, an emergency room, call 988, whatever it is, the resource or policy in your office, but that child needs immediate further evaluation. If they're not, the answer is no, meaning I'm not having thoughts right now, then you'll move on through the BSSA. And you're going to ask specific questions related to suicide plan. And this is really important, because the child may say, yes, I've had thoughts of suicide in the last, 3 days ago. Do you have a suicide plan? No, I don't have a plan. I would never act on that. Then it's really important to say, well, if you were to, have you ever thought about what you might do? And if the child is really detailed in their plan, that is a high acuity risk, and I would send them for further evaluation. But if they've never had a plan, they've never really thought about it, they just have these passing thoughts, they're not a high acuity risk. And that's likely a child that you can send for further evaluation for a therapist, not an emergency room. You want to assess for past behaviors, meaning, remember, we talked about the number one risk factor is a past suicide attempt. So knowing that escalates the risk for that child. Now, that doesn't mean that child who maybe had a suicide attempt a month ago, 6 months ago, 3 years ago is at extreme risk. It just means something that I have to keep in my head as I go down on the BSSA. We're going to assess for symptoms. And so those symptoms might be things like depression or anxiety. So anyone that has a diagnosable mental illness is at a higher risk. So understanding that. This social support and stressors includes sort of both the stressors and the protective factors. So knowing what's in place for that. Are they having bullying? But who is their support network? Do they have a lot of people in there? Yes, I'm being bullied, but I feel very connected to my school counselor, and I have a lot of support with my other friends. It's really important that we interview the patient and the parent together. And when we're doing this component of it, we're trying to get a sense of what is the child's understanding of what's going on and what is the parent's understanding of what's going on. And then it's also important to ask the parent, is there anything that you'd like to tell me outside of the room? Because I definitely have worked with parents that don't feel comfortable talking about certain things in front of the kids because they're worried about how the child will take it, perceive them, that kind of thing. And then we're going to make a safety plan with the patient. And we're going to make a safety plan with children who are at moderate risk But honestly, even the child who's at higher risk, because they're going to be sitting in your office for a bit of time before they're going to go out somewhere. So this is a really great opportunity to come up with a conversation with the child and the family to think about what can we do? What are the things that we can put in place that help you feel safer? And we're going to talk a little bit down about what a safety plan actually looks like. And then at this point, you're going to determine the disposition. And that'll depend on some of the data that you gather on whether this child is a low risk, a moderate risk, or no risk at all. And that really is based on all of the things that you gathered. So we're going to wrap this presentation up in this last section on breaking out how do we care for kids who are in these various categories, the imminent risk, the moderate risk, and the low risk. Specifically, how do we talk to the child and how do we talk to the caregiver? What kind of tools, what might we use, like the safety planning and lethal means counseling? So that first group of kids are the kids that are at imminent risk for suicide. And what you're going to notice in each of these categories is a lot of similarity and a lot of what we talked about from this prevention approach. So we're going to start with listening without judgment. We're going to use that active listening. We're going to say things like, thank you for sharing your thoughts with me. It can be hard and scary to share your thoughts of suicide. And I want you to know that I think you're very brave and I'm here to help you and you're not alone. That is a really powerful statement. Now, I don't say exactly like that, right? I make it my language, but I always have said to a child who has been brave enough to share their story with me, specifically around suicide, thank you for sharing that story with me. I know how hard that was for you to talk about. We're going to explain that confidentiality scenario. We're going to let them know what to expect. And this is really important. It's really scary for the child to be able to tell you this and then sit not knowing what the next steps are. And the last thing is super important. We want to empower, these are more the older kids, certainly the middle and high school kids, and giving them some voice and choice and how they want their caregiver to be told. Their caregiver has to be told. But we can ask them, would you like to tell your family? Would you like me to tell your family? Would you like me to sit with you while you tell your family? Would you like to sit with me while I tell your family? I've had kids answer in a variety of ways. I've had kids saying, I can't tell them, and I don't want to sit next to you while you tell them. And so I arrange for a safety person to be with the child while I tell the caregiver. And then with regards to the caregivers of youth that are at imminent risk, it's really important that we think about our words. Remember those hopeful messages. That we avoid language that places blame and makes them feel guilty. So unintentionally saying something like, did you know anything about this? And that's our attempt to try to gather information, but it can often come across as accusatory. We could instead say, I can imagine how hard it is to hear this. I'm wondering if you have had any concerns, anything that you noticed over time. Again, that active listening. Sometimes when we get anxious, we tend to talk more, listen less. Listening is incredibly important. Informing them of next steps in the plan. Connecting them to care. And while it may seem like, do I really need to talk about lethal means counseling when I'm sending them to an emergency room? Aren't they going to talk about it? Well, I hope they're going to talk about it. But it doesn't hurt to talk about it as many times as possible. And lethal means counseling means asking the question, are there firearms in the home? If the answer is yes, the recommendation when someone is at high risk that firearms are removed from the home. And if that is not an option for that family, then having a clear conversation around what safe gun storage is and looks like. And in a couple of slides, I have a QR code that navigates to an article that our CHIP doctors wrote on exactly that. But it also means safely securing medication, both over-the-counter and prescription medications, and having a conversation regarding things that can be used as suffocation and monitoring that. So things like belts, shoelaces. The next group of kids are the kids that are at high risk, but they need further mental health evaluation. And ideally, that would be the child that you would either help set up with a mental health professional within 72 hours of the assessment, and that you yourself also probably do a follow-up call with them. So again, that same things that we did with the child at high risk, we're going to do here. We're going to thank them for sharing. We're going to talk about the confidentiality. We're going to listen without judgment. We're going to let them know what to expect. You were really brave to talk to me about this. And I'm going to work really hard to get you connected to a mental health professional so you have someone to talk to. And then you're going to ask them, how would you like your family to know about this? Would you like to tell them? Would you like me? And then those same things with those families, the same things we did in that first scenario, we're going to do here. This is when we want to sort of begin to talk about the idea of a safety plan. And I'm going to go over that in the next slide. If you want to navigate to our article on safe gun storage, that QR code navigates there. You're going to give them information on 988. Hopefully that wasn't a new number that you heard in the video, that everyone is aware of 988. It rolled out in July of 2022. It is a 911 equivalent of mental health crisis. It is staffed by mental health clinicians who are trained in crisis work, and it is 24/7. It navigates in our state through the Georgia Crisis and Access Line, which I'm pretty proud of. There are many things in Georgia from a mental health perspective that we're behind in. This was not one of them. So when 988 rolled out in July of 2022, we actually were better equipped than other states because we had a system in place already. Additionally, on our website, and Rachel's going to go over all of our different resources later this afternoon, but we've also created this teaching tool that I'm really proud of, Behavioral Mental Health Services, that educates families on who are the various kinds of clinicians that provide mental health care. A lot of families are aware of what a psychiatrist is and a psychologist, although I will say they often flip who does what in those two degrees, but they don't know my credential, and they don't know an LCSW, and they don't know a licensed professional counselor or LPC. And those two disciplines often provide, and LMFTs, the largest workforce of mental health support. So helping families understand that, and that's laid out in the first half, as well as all the evidence-based treatment that we use in pediatric mental health. And the back of the page is, if I'm looking for a therapist for my child, what kind of questions should I be asking as I'm looking? And then once my child's in therapy, what should I expect? The next is a safety plan. So safety plan is not a safety contract. It is not a legal document. It is simply a way that is organized and involves the patient and the family to think about the child's crisis signs, some coping strategies, supports that are in place. And this is an example of the safety plan that we use in Children's Healthcare for Atlanta. It is available if you honestly, truly Google safety plan. This one actually comes up, and you just have to get permission. I'm on the State Suicide Prevention Task Force, and in our meeting on Wednesday, they announced this safetyplan.org, which I highly recommend. I navigated to it last night, actually, for the first time. And you can actually download an app which allows, and so the patients can put that on the phone to digitally do one in real time, or you can print out a handwritten one as well. And so all classic safety plans are categorized in this way. And so the first part of a safety plan is always about having the patient identify what are the warning signs that tell me that a crisis is brewing. And sometimes this is tricky for a kid to figure out. And so you might have to use language that makes sense to them. So it might be like, when do you notice that you're really, you're really going to have an outburst, and really get specific about that. And that's usually how I can get kids to sort of think about what their body feels like, sort of what are the things that are happening around them. And then the next is, what are coping skills that only you can employ? Meaning you don't need anyone's help to do that. What are the things you have internally that help you feel better? And then who are the people or social settings that provide distractions? So these aren't therapeutic people per se, meaning they're not professionals. And so it may be that when I take the dog for the walk is something that provides me a distraction, or my grandmother's house is another place that I enjoy going to. And then who are the people in your life that you can ask for help? And I will say, when I'm working with teenagers, they will always want to put all kids on there. And that's completely developmentally appropriate. But I encourage them to put at least 2 adults and then 1 youth on there. And then the last, or step 5 of there, is the professionals. And so some kids may not actually have a professional in their lives, but if I've connected them to somebody, that's where I'll write the person's name for the first time, unless they already have a therapist. And then ensuring that they have the 988 number there, and the local urgent care services or the community service board in your area would be a great resource to put on there. And then the next step 6, is making the environment safe. So that's where that lethal means counseling can come in. And it's a great time to have direct conversations about asking about firearms in the home. And then the last one is that really important thing around hopeful messaging and protective factor, which is what is the one thing that is the most important and worth living for. This is a really powerful statement. And I couldn't tell you how many times a child has struggled with that, but when they finally are able to say that, the relief that leaves sort of the parents, that they have something that they can hold on to, is important. And then the person doing the safety plan signs it, the patient signs it, and the parent signs it. You keep a copy for the original copy for your medical record, and I always make a copy for both the child and the caregiver. And then the last group of kids are the ones that are at low risk. And this is those kids that have that history of suicide in the past, or maybe they've screened positive on the PHQ-9 adolescent because that's what you're using in your practice. Or if you're screening for anxiety, they screen positive for anxiety. So this is a time where we really want to be intentional about educating about protective factors, ensuring those coping skills, those problem-solving skills. That we're talking early and often about suicide and we're not avoiding using that word, and that we're validating all of their feelings. And same for the families. This is a time that we really want to educate them. Sometimes when families have a child that has had a previous suicide attempt or thoughts of suicide and they're past it, they don't want to think about it again because it was so hard for them to live through that they think we're done with it. And it's really important for them to know that their child's at higher risk than the general population, so they just have to have it on their radar. That does not mean that they're walking on eggshells for the rest of their lives. It just means it's not something they can forget about. We're going to give them mental health referral options if that's indicated. We're going to talk often. And again, we're going to have opportunities around lethal means counseling and being really intentional about that. So as we wrap up, I think it really is important to equip ourselves with how do we talk to youth after a suicide has happened? And this can be really scary because we don't feel comfortable as humans about that. And I can say that when I came back to work at Children's Healthcare of Atlanta after my husband passed away, I watched people struggle with what to say to me. And they would hover at my desk and I would have people saying, I don't know what to say to you. And my response was always, well, if my husband died of a heart attack, what would you say? And they were like, I'm so sorry for your loss. It's the same thing, right? It's not any different. And we need to equip families with the language to be able to talk about that and to talk openly with their kids. So when we think about the littles, or any of these kids for that matter, we're going to ask them what they know from an age and developmentally appropriate approach. But we're always going to let them lead the conversation. And when they're real little, we're going to keep it simple. Okay? Short answers. The person had a disease in their brain and it took over, might be an example of what we might say. When they're in elementary school, we might give them a little bit more information. But again, we're going to be really mindful of the details, but we're not going to avoid talking about that the person died. By the time they're in middle school and high school, however, they have heard this at school. And they may very well have known someone who has either attempted suicide or maybe even died by suicide. So again, asking them what they know about suicide. I know this is something that's in the news a lot and that kids are talking about. Tell me what you know about suicide. And following their lead. Specifically for the middle school kids, this is a great opportunity for you to dispel any misconceptions that they have around suicide, because they likely have a lot. By the time they're in high school, they may be struggling themselves with suicide. So this is an opportunity for you to ask the direct question, have you ever had thoughts of suicide? I also want you to know that it's normal for people to struggle with things like depression or anxiety. So if you have those kinds of thoughts or feelings or worries, I want you to know that coming to me and talking to me about it is okay, and that there's help available and these can be treated. These are incredibly important things. When my daughters and I created this video and it was released in September for Suicide Prevention Month, and it was released within Children's and it was released on social media and everywhere, I was flooded with countless emails and texts from people that I knew. But one in particular stood out to me. It was of a nurse that I didn't really know that well, who based on the video went back and had an intentional conversation with her husband. Have you ever had thoughts of suicide? That was not something that they ever talked about. And she learned that her husband had fleeting thoughts. And just by having that conversation, they created an opportunity for that to feel okay to talk about. And they made a commitment to regularly check in about their feelings and make it normalized and then model what that looks like for their kids. So we all have an opportunity by having these frank conversations and not being scared to talk about it. We don't have to have all the answers. We can admit, thank you for sharing that with me. I don't know exactly all of the sports, but I know who to ask for. I know who to ask for help, and I'll gather more information. I've listed a bunch of resources for you all, and I will make sure that Kedrick sends these PowerPoints to you in a PDF form so you'll have the resources. And then Rachel's going to go over all of these resources that are attached to our Building Resilience training, but these are also available on our website. So if you want to encourage families to navigate them, really what these do, these coping skills and feelings posters, by printing them out and putting them on refrigerators, is you're creating opportunities that normalizes that we all have feelings and that we all should be proactively practicing coping skills. We have these community resilience tip sheets, and we have coping skills tip sheets. And then I'm really proud of our Raising Resilience campaign that launched in 2021 that our video is a part of. And I encourage you to encourage your families to navigate to these resources. They can sign up for our Raising Resilience email series. And no matter when they sign up, they'll get the emails from the beginning and then get them in a sequential order. And if they go to our website, raisingresilience.com, it is crafted in a way that if I'm a parent of an infant and I only really can handle reading articles on how do I build and foster resilience in my infant, I can just click on that one section and navigate all the content that we have on there. You can follow us on social media. And then I do encourage you to check out our other videos. I'm really proud of all of the videos we've created. They're real families and real people who have various kinds of ups and downs that they've faced and are willing to share their story of various kinds of lived experiences. So I'm really tight on the time, but I will allow for any questions that any of you all might have.
Thank you so much for sharing your story. This may be a long-ended question, but when I have patients, whether a child or an adult, who says they want to die and they may have a suicide plan, I always struggle with how to approach going to a hospital. Of course, I've done that, but a lot of times your patient will not want to do that. Oh, I'm not really at risk. I'm not really planning to do that. I don't want to go to a hospital. I just want to start medicine. I want to see a counselor. And it's kind of hard to employ making them go or really suggesting that. Any way to navigate, any tools that you would recommend?
So I think that's when I can speak more for pediatrics than I can speak for adults, because adults are not my area of expertise from a tool perspective. I think that is where when we use evidence-based screening tools. So if a child is sort of articulating that they're having thoughts for suicide and say that it isn't something you universally screen for, but they make that statement, then I would use the ASQ as a way for me to help understand, is this an acute risk or is this a non-acute risk? Because it's a standardized approach. And if it's an acute risk, meaning they say, I'm having thoughts of suicide now, then I would then move into the BSSA form, which then helps me understand, is this really a child that I have to send to the emergency room? Or is this a child that I can put a safety plan in place, that I can connect to a therapist within 72 hours? And I appreciate that in this area that may not always be possible, but with telehealth, I feel like we've gotten better at having a little bit better access, but they could at least come back and see you within 72 hours. And so I think that if you use this sort of standardized approach, I will guarantee you there will be a much smaller percentage of kids that you actually have to send to the emergency room. But in the pediatric population, if you assess that a child is at a very high risk, then you are obligated to have them go to the emergency room and have further assessment. And so that it absolutely gets tricky. I couldn't tell you how many times in the emergency room where we determined that that child's a high risk and then needed to be psychiatrically admitted. And you get into this struggle with families, but usually I will say that I can probably only remember in my 16 years at Children's and my 35 years in being in this space, a very small percentage of like 3 families that really continue to push back. And a lot of times when families are pushing back, it is because they are petrified. And it's based on the stories that they've been told and spun about what happens when a child is hospitalized. And so when I can alleviate their anxieties around that and we can partner together, I usually can get families to agree for further assessment and evaluation. But I think a standardized evidence-based approach is the best way to go.
Yeah, thank you so much for the presentation and your story. The screen you mentioned is good for children. If you're in an integrated practice where you're seeing adults and kids, how far should you use the different screening tools? Up to what age? 20, 25? So when you have those integrated practices, or you're a pediatrician who's seeing kids up until they're 25, is this tool still work for that population? So where's the cutoff? And then what might you recommend in a transitional phase?
So the ASQ is evidence-based up to mid-20s, and the Columbia has an adult version of that as well. So I can't specifically speak to like what age range, but there are adult versions of both of that. And then the ASQ, while it first started in just pediatrics, it has expanded over time. So you're safe to use the ASQ with an older population as well.
Great. And what's the recommendations to screen up till?
Oh, everyone.
Everybody?
Everyone.
So over, so teenager and then above through adulthood.
Correct. The recommendation is truly to be, ideally, to universally be screening everyone. And when we universally screen, what we're doing is we're chipping away at stigma. We're saying that we take this seriously, and so we're screening everyone, just like we screen for all other kinds of health adversities, right? When we do that. But we don't feel super comfortable with the screening everyone, and we don't have enough mental health professionals in there, and so that gets in the way, and that creates a barrier.
I'm just trying to reflect if I've ever been screened before when I go to my primary care provider. I don't think I have.
I have never been. Yeah. And I will say that, you know, my children are older. They're 29 and 23. So they didn't even get the PHQ-9, which is a lot of practices are using now. And they got more of those standard questions, which you knew, like Bright Futures was getting into a place of having pediatricians ask questions around depression. And so my younger daughter, who is now 23, she was 12, her pediatrician, the way in which she framed it, and our pediatrician was wonderful, but you could tell she just didn't feel comfortable with this stuff. And so she said to my daughter, you don't ever feel sad, do you? That was her way of screening for depression. And when we got in the car, Izzy said, well, she clearly didn't want to know that I was feeling sad. And this is my youngest, who's not in the mental health field and not the most touchy-feely. And she picked up on the uneasiness in the pediatrician's practice. But that really came from a place of, we haven't done a good enough job helping support people to feel comfortable around behavioral mental health topics. And when we don't feel comfortable, we're going to say things like that. And that's just, you know, we have to get better at supporting pediatricians in providing them education around behavioral mental health topics.
Thank you.
Mm-hmm. Any other questions? I know I'm keeping you all at lunch, so that's an important thing. So thank you, everybody.
Mm-hmm.